I want to get right into it. So for those who didn't listen to us a million years ago, I want to talk about your practice with liver tumor ablation. And look, there's a lot to cover in this stuff, and I want to get to the more esoteric stuff. So I just really want to jump into your technique. Like whenever you're thinking like liver tumor ablation, like how you approach a lesion, and then what's kind of your process as far as approach and technique.
Oh, that's that type of question for me. I'm thinking about 5 hours now. But anyway, what I really
well worth it for the audience.
One thing that I'm known to say in my practice, and this is the way I view microwave, that microwave is like a Swiss Army knife for IRs. It's versatile, powerful, and increasingly sophisticated. It's been getting increasingly sophisticated. It's not just some needle that you use to burn some tumor and say, no, it's too dangerous to use here, it's too dangerous to use there, and just limit it to really chip shots. So when you really master it, once you've done more than 1,000 cases, then you realize like, whoa, I can do so much of this. So to answer your question, it really depends. There is the chip shots, and there are non-central lesions, preferably in a patient that's not really close to the capsule or to the abdominal wall. There are lesions that are pericardiac, next to the heart, defined as lesions where the end ablation zone is going to be within 5 millimeters of the heart. So that's a difficult situation. There are lesions where, the lesion is so much in the dome that not going through the pleura is impossible. Then you have the conundrum of, do I provoke a pneumothorax, or do I just see whether actually a pneumothorax even would happen if I go through the pleura? So really, I published about this. There is a lot of publications because there is just a lot of techniques. It really depends where you are. Are you working through the right lobe, where you have to go parallel along the hepatic vasculature? Are you working to ablate something in the left lobe where parallel is completely a different direction? Because you don't want to stick that artery directly and dissect it. So we can go on for hours and hours and hours to describe how to do a liver ablation. For me, the basics. What are the basics that make what I do a little bit different? And I've spoken to a lot of other people who tell me, oh, okay, that's different. Oh, that's different. I'm like, well, I can't remember the last time I've had a major complication. I'm not going to knock on wood right now, just not to make a lot of noise on the microphone. But most of my procedures, in general, I start with what's called a pre-burn. And it is something that a lot of my colleagues have told me, well, Driss, we have read a lot of your papers and you only mentioned it in one or two. And I'm like, yeah, you're right. I'm sorry. I have forgotten to do that. My bad. I'm not trying to keep a secret from anyone. I just it was an oversight. So what is a pre-burn? A pre-burn is most of the lesions, and specifically the capsular ones, specifically ones who are in very dicey locations. I usually start my ablation with a 45 watts, sometimes 75 watts, but 45 to 75 watts, 1 minute ablation. Why do I do that? Several things. I like to do it to fixate my needle. So my needle does not move. It's more important in actually the left lobe, where actually your needle is mostly outside of the patient. I like to desiccate the tissue. The desiccating the tissue decreases a lot of the water content. Why do I want to decrease the water content? I think a lot of it now exactly why. You decrease the water content, you accomplish two things. You decrease the heat sink that is going to happen after you start your true ablation. That's one. The other most important one, that's the reason why I started in the first place, is because I was tired of hearing capsular bursts. You hear them all the time. If you've been ablating enough, you should have heard a lot of capsular bursts. I've learned that from doing ablations from the surgeons, where it kind of sounded even more scary. A lot of groups were telling me, oh, I have capsular bursts all the time. Patients are bleeding. And I'm like, gee, my patients are not bleeding. So that's kind of unusual. I don't know why your patients are bleeding. So what else do I do? After that, I am very meticulous about my tracts ablation after that. And one of my rules that I always told even my junior faculty is, if you stick it, you tracts ablate it. People who put the needle, I was like, let me adjust it. Well, before you adjust it, tracts ablate it. I have seen tumor seeding happen. It's not common. It's very unlikely to happen, but I've seen it happen. And the cases where I've seen it happen, when I reviewed the techniques, that was missing. The tracts ablation was missing. The tracts ablation of after modification of the location. So that's a small intro of what my technique looks like.